Dear Professor Chiba, the- including the University of Belgrade and Novi Sad as well. He is a member of numerous national and international societies, doctor of the Hungarian Academy of Sciences, founder of Hungarian Neurosurgeological Society, and past president of the European Society of Neurosurgery, to name only a few of his affiliations. Moreover, he is a dear friend who is always willing to help and support younger colleagues. We are therefore especially proud to award him with Laza Lazarevic Award for exceptional contributions to neurological sciences. Professor Kostic.
Dear Professor Chiba, dear colleagues, Award Laz Lazarevic has been initiated 2 years ago, and this is the second actually occasion that we are giving to our outstanding distinguished neurologists who are also, for us, in this moment particularly, dear friends and collaborators for many years. What is the meaning of the award Laz Lazarevic? This is the essence actually of the person who is the father of a modern Serbian neurology, a man with a very tragic history. He lived, believe it or not, only 40 years, and for these 40 years he participated in 3 wars. He studied in Berlin, where he has to stop his studying because of the historical circumstances, but coming back, and when he finished, he introduced such an energy actually in the Serbian society. He was the founder of several outstanding institutions, including the first actually geriatric institution in Serbia. On the other side, he has a very broad field of interest, but main of his 75, believe it or not, 75 scientific works at the age of 40 years at that time, some of them published in the Berlin and Vienna. His main work was on sciatica, radicular syndrome, which has been published actually in Vienna. But he also done a lot of other pioneering works. For instance, he was the first neurologist in Serbia who reported Parkinson's disease, believe it or not, in one guy from Požarevac, who was found actually. To my opinion, he is also, not to my opinion, he is definitely, without my opinion, one of the fathers of Serbian realism in the poetry, in the writing. He was a very successful writer. And such a flamboyant life was in the frame of tuberculosis, which was the follower of all our poetries at that time. Barring not only the members of his family and his dearest, finally he was the victim at the age of 41. But now, when we look at the past and see what he organized for us, it's really outstanding and very difficult to understand how, in these tremendous turmoil times, he was so successful in giving some bright ideas to this society. So for you, this is a kind of award, but also a kind of sentence that maybe also in the way you are behaving and doing your work in Hungary, there is something maybe like a taste of similarity. So this is a compliment.
Thank you very much, dear friends, dear colleagues. It's very nice to be here again. And first of all, I should like to tell you that Lazar Lazarevich, or Lazar, as I have read in his biography, had a typical Eastern Middle European faith, but very optimal one and very fantastic one, because he went for collecting informations and knowledge to Berlin, and reached also the doctor thesis in Berlin, but returned. But I'm persuaded that Lazarevich had a much, how to say, more simple way of life in Berlin in that time, or in Germany or France, because he was so talented, skillful, and clever. But he returned in order to, to help his country, to help the suffering people here. So a very short overview about the fate of this genius, already mentioned by Professor Kostic, some words about it. There is a Latin saying that I hate the people who has only one book. It means that if somebody is too simplified and too narrow, it cannot be a good guy. Lazarevich was not a one-book man. He was multicultural, and he had many so-called books. As you see, he himself translated, for example, a book from the Gogol, the Russian talent, The Diary of a Madman. And as Professor Kostic mentioned, he learned a lot in Germany. He learned a lot from excellent people, Helmholtz, Westphal, Virchow, etc. After finishing the studies in law, he was already a lawyer, and the lawyer earns always more money than the physician, but he refused to do it and continued to be a physician. And fortunately, also the Serbian people acknowledged his efforts, because he became the doctor of the royal court, nominated by the king himself. And I think that Professor Kostic has totally right, because he's a founder of the neurology in this country, and his wide interest wide focus of interest was really very amazing, because he has published papers about aphasia, paralysis, agitans, and psychosomatic disorders, relation between mind and body. So really colorful and interesting and very, very sympathetic personality. Every day, if we investigate the patients with low back pain, actually in the background is always Dr. Lazarevich there, because his shadow is with the Laseg or Lazarevich sign, strength by the sciatic nerve. And on the other field of the personality, the short story writers, and these short stories come from the very intimate atmosphere of a close and nice small village that he came from. If I correctly remember, he was born in Sabac with 3 sisters, and the father died very early in age of 11, and his sister who had to take care of him, and the wife so the mother sacrificed her life for the benefit of the family, and this was the milestone for Dr. Lazarevich. So I think he should be really a very nice mark for the future, for the neurologist of the future. And I am very happy to hear and to see that even after 150 years after the death of this very, very young, unfortunately very young genius who died in age of 40 on tuberculosis, that his country did not forget him. On contrary, even the stamp has been put onto the market 150 years after his birth in 2011. So Now I should like to speak about some interesting verbs and films, and I hope it will not be very boring for you, about neurosonology. Before to start my lecture, don't worry, I will not speak 1 hour. But before to start my lecture, I should like to draw your attention that next year, in May, May is always beautiful in our countries. In Budapest, we will organize the European conference of the neurosurgeon. Please come and participate. I think it will be very interesting. Ultrasound. About 70 years ago, or 60 years ago, 67 years ago, this was the first ultrasound picture done in the United States. Echocardiography. The machine is a little bit huge, and the man is sitting in the water because it amplified the picture. The first ultrasound picture is also not so young. Perhaps the baby is already 31 years old, but this happened in 1986. During my lectures, I should like to prove that the application of the ultrasound in the neurology has a very wide, a very broad spectrum. For example, we can get information about the heart and brain interaction. We can receive information about the morphology and function of the carotid and vertebrobasilar system and circulation. We can get insight into the intracerebral hemodynamics, very important because the MRI and CT has an excellent resolution, spatial resolution, but the time resolution is much, much better if you think of the transcranial Doppler. You cannot make serial, so 1 minute registration with PET. You cannot make a continuous registration with MRI, but you can do it with ultrasound. With 2 megahertz or 2.25 megahertz, you can get important information about the flow in the skull. And finally, you can combine the neurosociological investigation with other techniques, for example, cognitive testing, neuropsychological testing. So, some words first about the heart and brain interaction. You know very well that about 20% of the ischemic stroke are caused by cardiac sources, including atrial fibrillation. And using the transcranial Doppler, you can detect the microemboli. The microemboli are practically clinically silent events, but millions or thousands of microemboli can provocate dementia, can provocate any other psychological problems. And now we have already some criteria for detecting the microemboli. We know what are the criteria for the microemboli. And just now you could have heard a microembolic signal. And this microembolic signal can be detected during carotid endarterectomy, during coronary bypass surgery. And it seems to be if the patients after the coronary interventions came out from the operation room without any neurological deficit. But if you measure, the patients will have decreased cognitive ability because millions of microemboli have been dislodged during the clamping, during the cutting the vessels, etc. To filter them or to block them could be very important for the future of the patients. Nowadays, we can discriminate between microemboli and microemboli. Is it a new clot? Is it a mixed clot? Is it a homogeneous plaque? Very important questions. In order to demonstrate how can you use the neurosonological methods, I should like to show you this short work coming from our institution. In cooperation with the cardiologists, we investigated the microemboli signals during 3 types of intervention: cooling, blocking the abnormal rhythm with cryotechnics, or with radio frequency ablation, or combination of them with anticoagulation. And here you can see that using our technique, we could compare how many emboli happens during the cryotechnics, during the radio frequency ablation, and during the third techniques if you combine these techniques with anticoagulation. Jumping to the carotid vertebrobasilar systems. In the practice, almost hundreds of neurologists use in this moment, probably also in Serbia, for the detecting of the carotid stenosis, the ultrasound for detecting carotid stenosis or occlusion. This non-invasive technique is absolutely useful to follow the arteriosclerosis. Here you can see the progression of the arteriosclerosis. The intima media is normal, increasing, further increase could be seen, irregularity could be seen, and finally this is almost reaches the size of a plaque. So the resolution below 0.1 millimeter. Of course, extremely important to use the carotid ultrasound for the detection, non-invasive detection, repeated investigation of the carotid bifurcation, because this is one of the most important localization of thrombotic cause of ischemic stroke. Important to know if we see the external carotid, you can diagnose and identify using the profile, or if you investigate the internal carotid artery, because the hemodynamic profile is totally different. The stenosis itself will provocate abnormal flow, rotation, and many other alterations. And this alteration, together with the morphological information, could help you to diagnose the severity of the stenosis or to diagnose the occlusion, using the velocity and using the grade of the stenosis, putting together. Of course, not only the severity of the stenosis counts, but also the composition of the plaques. Because many asymptomatic patients are operated. For example, in the United States, perhaps 80% of the patients who are operated are asymptomatic. And we all know that only very few % of the asymptomatic carotid stenosis will provocate sooner or later stroke. But who is the guilty guy? Who is the dangerous? Which one is the dangerous plaque by asymptomatic? This is a crucial question, and this should be known by us in order to pick up and to select those patients who really have to be operated. And in this question, to answer this question, the ultrasound plays a very important role, not only in the measurement, the IMT, because if the IMT is increasing after a given limit, behind or over a given limit, it will turn into the plaque. And these new techniques will get the information, will provide information about the surface of the plaque. Is it ulcerated? Risk for stroke. Or smooth, regular, low risk for stroke? Or what about the ulceration? It turned out, and it has been proven, that the higher is the number of the ulcer, the higher is the risk for stroke by asymptomatic patients. And you can repeat the investigation anytime. So not only the severity of the stroke, not only at the surface of the plaque, but also the homogeneity of the plaque counts. And how big is the hypoechoic, so probably inhomogeneous plaque, high risk for stroke? As this paper shows, the higher is the region of the hypoechoicity, higher the black spot, the higher the range, the surface, the size of the hypoechoic plaque, the higher is the risk for the devastating stroke. The new techniques, B-mode, together with or without contrast, can give more and new information regarding the plaques and plaque vasculature and plaque vascularization. Here, for example, with the traditional ultrasound, duplex ultrasound color and the morphology did not show this intimal flap. Here you can see the green area. With the new techniques, it's visible, and these abnormal findings in intimal flap could be confirmed by the catheter angiography. Similarly, again the question comes back, again the same question, which is the vulnerable plaque? And using the contrast material, you can see the new vascularization of the plaque that shows also that's very specific and can help you to select the very high risk plaques. These plaques can be, as I mentioned, smooth, can be ulcerated, can be homogeneous, inhomogeneous, can have new vascularization, but can have also microemboli. And all the ultrasound, the transcranial Doppler, the neurosonology has the only device and tool that can identify the microemboli positive patients with 1 hour, 2 hours, or continuous detection. Here you can see, for example, those patients who live without microemboli, with plaques, but without microemboli, and those patients in high risk for stroke who have microemboli by detecting with transcranial Doppler. And the moving plaques, the floating thrombus, this is the only tool that can show you the moving plaques, and the moving plaques should be immediately removed because in the next moment, the next day, or the next hours will provoke a devastating stroke. And the only tool that can show you that this is not a stable plaque but a moving plaque, floating thrombus, is neurosonology ultrasound. We enter into the skull. The skull is in a bony space, but the new ultrasound techniques and beams can penetrate on some specific places and sites into the dog. Don't forget the simple ultrasound. You don't need machines, not only machines with a million of euros or 100,000 or 10,000 of euros. Please don't forget the simple techniques, bedside techniques. It is also very useful in the everyday practice, even in the private practice. You can measure the ophthalmic flow with a very simple and cheap device. For example, the collateral flow comes from the external carotid artery, and the branch of the external carotid artery by these patients was the facial artery. By compressing the facial artery, you can identify the source of collateral circulation. And what is the clinical consequence? By these patients, the external carotid artery should be followed, and if necessary, to make it to dilate it, to operate the external carotid artery, because the external carotid artery by these patients plays an important role for the collateral circulation, because the ipsilateral internal carotid is already occluded. By these patients, the temporal superficial artery was an important source. Jump to the intracranial space. You can see how well we can identify the intracranial vessels, and now in the next slides you can see how sensitively reacts to the hyperventilation the cerebral blood flow. The young patients will make a hyperventilation with constriction of the vessels, and you can see how the flow is decreasing after some seconds of hyperventilation. Oh, sorry. the transcranial Doppler could be used also for detecting after occlusion or stenosis of the intracranial vessels. As you see, the diagnostic accuracy is different from supratentorial, between supratentorial and infratentorial region, but the big advantage is not only to detect the velocity, but now with the new recent techniques you can visualize and you can see also the collateral flows, which artery provides the collateral flows, which artery is occluded, etc., etc. And now we have to continue with the stroke risk patients, because up till now we spoke about the importance of the ultrasound in the stroke patients, and now we jump to the stroke risk patients. The stroke risk patients should be also and can be investigated with ultrasound techniques. Who are the stroke risk patients? With hypertension, with hyperlipidemia, diabetes, cardiac source of emboli, etc., etc. What is the hemodynamics, the cerebral hemodynamics? What is the autoregulation of the cerebral blood flow? How can we investigate? If we find the restricted autoregulation, can we apply a more aggressive antihypertensive therapy, more aggressive lipidemic therapy? Yes. The answer is, of course, yes. But how can we find these patients? Because one patient with diabetes will suffer from cerebral impairment, the other will not. How can we select them? There are different techniques. For example, CO2 inhalation or giving diamox, acetazolamide, dilates the vessels and increases the blood flow. Here you can see the transcranial Doppler can test the cerebral blood flow changes after provocation test, before and after the provocation test. What happens in the brain during this provocation test? If you make, for example, CO2 inhalation or acetazolamide provocation, then you will dilate the vessels and the velocity increases. By hyperventilation, you will provocate vasoconstrictions and the flow will decrease. Here, for example, some slides from our studies investigating symptom-free, young, probably only suffering from hypertension only from 8-10 years. And you could see that the curve of the hypertensive patients is significantly different. This curve shows the velocity increase after acetazolamide provocation. This is the control curve, and this is the hypertensive patient's curve without any neurological symptom. The cerebral hemodynamics is already impaired. The same could be detected by diabetic patients who have already 10 years duration. After 10 years duration, this reactivity curve is totally different from the control, although the patient has not yet received or suffered any stroke. The breath holding index is also a provocation factor because the patient retains the CO2, not taking breath, and you can see the patients who have decreased vasodilation during the breath holding index has a higher risk for stroke. This slide summarizes our more than 15 years activity in this field, investigating the effect of aging, hypertension, hypercholesterolemia, smoking, diabetes, and migraine on the cerebral hemodynamics. And here you can see what did we find in this group of asymptomatic but stroke risk patients. As you see, the transcranial Doppler, this simple tool, is a sensitive device for detecting the impaired cerebral vasoreactivity in different groups of vascular risk patients. Totally new field is the therapy with ultrasound. The The ultrasound has a heating effect, has a cavitation effect, and you can use it for for shaking the thrombus to accelerate, for example, the efficacy of tissue plasminogen activator. Here you can see the patients who had continuous transcranial Doppler insonation, and this insonation not only detect the recovery of the flow, but also enhanced the thrombus TPA interaction. Microbubbles, if you inject microbubble into the thrombus and then penetrate the ultrasound like a bomb, the microbubble will blow up and will also help to the TPA to blow up, to destroy the thrombus. So TCD with microemboli, so ultrasound insonation with microemboli and TPA can enhance the efficacy. Here you can see if you use simple thrombolysis, the improvement is 37. If you combine it with ultrasound insonation, the efficacy rate is 51%. Finally, some words about the cognition and vascular risk factors, because this technique can be very, very well combined with other important techniques used in the neurology. Here we investigated, for example, the intima media thickness change, compared the control with the age-matched hyperlipidemic patients, only hyperlipidemia, only hypertension, or combination of them. You can see if somebody is combined, he has two risk factors, hypertension and hyperlipidemia. Unfortunately, the speed of the intima media thickness is significantly worse compared with those who have only one single risk factor. And we investigated the cognitive test, cognitive performance of this risk factors, hyperlipidemic patients, hypertensive patients. For example, here you can see the reaction time to light, to noise, the combination of them. And as you see, not only these tests were used, but many others. And finally, we summarized the stats and we gave one score, putting together the results of all other tests. Here you can see that the sum of all 12 tests that we use for these risk patients, that if you put together the result of these 12 cognitive tests, you can see compared with the control persons that the hyperlipidemic patients, hypertensive patients, and the combination, so hypertension plus hyperlipidemia, you see that by those patients who have two groups of risk factors, they have already cognitive impairment based on this observation. So the surface is still calm, the sea is calm, the surface of the ocean is still quiet and Pacific, but in the depths there are already a volcano of the cognitive impairment or of the impending stroke. What happens after therapy? Okay, we have selected these patients have already some abnormality in the psychological test. What happens after therapy? And as you see, after 1 year antihypertensive therapy, all red spot illustrates one patient. And those patients who improved after the neuropsychological test, improved after 1 year therapy, are above the line, and those patients who did not improve could be found below the line. As you see, huge majority of the patients' neuropsychological performance improved after the antihypertensive therapy. So the antihypertensive therapy improves not only the blood pressure, but also improved the results of the neuropsychological testing. if the smoking is a dangerous risk factor for the stroke. Here you can see how is the effect of the reading. This is the closed eyes period, and this is the reading period above the posterior cerebral artery. And here you can see the reaction during reading by non-smokers and by the smokers. And those people who gave up smoking, have already an improving reaction to reading a book, and we detected the posterior cerebral artery flow. So I think that during this lecture, perhaps, I hope so, I could prove to you that the ultrasound in the neurology is more than a simple diagnostic tool of extra or intracranial occlusion or stenosis. It has a unique diagnostic ability, for example, microembolus detection or floating thrombus. It can be used also for therapy. Think of the microemboli, think of the microsphere, or think of the thrombolysis acceleration effect. And it can be used for monitoring and follow-up of natural cause of diseases, for pharmacological intervention, antihypertensive therapy, and during surgical intervention, for example, coronary bypass surgery, or endarterectomy, or abdominal surgery. So many, many new applications are on the horizon. And what's about the future directions? It's also very interesting because the development is continuous. Here, for example, you can see the brain of a rat, very small rat, and you can see using the very new technique of ultrasound, the epileptic seizure provocates flow changes. The flow changes measured by ultrasound flow. This is ultrasound picture, how the epileptic seizure provocates flow changes in the in the brain of the rat. But not only rat, but young infants who could be very well investigated, for example, with ultrasound, and besides the excellent morphological resolution, you can get such a fantastic pictures using the new special ultrasound techniques using 18 megahertz. And here you can measure using the probe the flow, for example, from the very teeny vessels, occlusion or stenosis. For example, here if you select a small vessel, you can see how the flow is changing, increasing or decreasing after therapy, pharmacotherapy, for example, in the infants, or by patients who has opened skull or removed bone flap.